Did you know that lateral elbow tendinopathy, well, the condition most of us call tennis elbow, affects maybe as many as 1 in 30 people every single year?
That's right. It translates to roughly 4 to 7 cases for every 1,000 adults.
And it's not just a minor thing, is it? It's actually the most common reason people have that persistent pain on the outside of their elbow.
Makes up about 2/3 of those cases, yes.
So if you've ever felt that frustrating ache yourself, or maybe know someone who has, definitely not alone. Welcome back to the Deep Dive. This is the show where we cut through the noise, take your sources, articles, research, maybe even your own notes, and really pull out the key insights. Think of it as a shortcut to getting properly informed, hopefully with a few surprising bits along the way. Now, this specific deep dive was actually requested by one of you, looking for some clarity on the latest evidence-based ways to manage this really common but often quite misunderstood condition. And helping us navigate the recent guidelines and research today is a leading figure in orthopedics, someone deeply involved in the very literature we're about to explore. He's been central in reviewing the evidence and contributing to the BES guidelines on this topic, which are key sources for our chat. It's a real pleasure to have you here.
Thank you. Happy to be here and ready to jump in.
Excellent. Okay, let's set the scene then with a quick rapid-fire round. First one, what exactly is lateral elbow tendinopathy, and why do we all call it tennis elbow? Seems confusing.
Well, at its heart, it's about altered tissue homeostasis. Basically, something's not quite right in the tendons that attach to the bone on the outside of your elbow, the lateral epicondyle. This causes pain, which often radiates down the forearm, and it frequently affects your grip or, your hand dexterity.
And the tennis elbow name.
Ah, yes. It comes from the fact that, well, it can affect tennis players, but honestly, overwhelmingly, it's linked to repetitive tasks or loading in daily life or work, much less often from sport. And the diagnosis itself is clinical. It's based on your history and a physical examination.
Okay, second rapid fire. We often hear this condition can just get better on its own. Is there truth in that? And if so, how often? How quickly?
Yes, that's a really crucial point from the evidence. A major finding from meta-analyses is that lateral elbow tendinopathy is largely self-limiting. Studies tracking patients who had minimal or no active treatment show really high rates of spontaneous improvement.
How high?
One key analysis found around 89% global improvement within a year.
89%.
Quite significant. It is. And what's perhaps more surprising is the speed of improvement. The half-life for significant global improvement is estimated around 2.5 to 3 months. And interestingly, this doesn't seem to be related to how long you've actually had the symptoms when you first seek help.
That's genuinely quite reassuring for people going through it. Okay, last rapid fire. Given how common it is, and that it often gets better anyway, why is there still so much kind of conflicting advice and debate about the best way to treat it?
That's a great question, and really sets up our deep dive nicely. The debate mostly comes from the varying quality and consistency of evidence for different treatments over the years. Past guidelines have sometimes offered different advice. The goal of recent efforts, like the BES guidelines we're using, is to apply really rigorous methods. Things like the grade system, which systematically rates the certainty of evidence to give clearer evidence-based recommendations. And importantly, to highlight where the science is strong and, frankly, where it's still a bit uncertain.
All right, bringing some clarity. Okay, let's unpack this then. Starting with the non-surgical options, which is where most people begin, isn't it? What's the recommended initial approach, say in primary care?
Yes, absolutely. Initial management really emphasizes shared decision-making. This echoes guidance from bodies like the GMC. It means properly listening to the patient, giving them clear, understandable information about their condition, what to expect, respecting their choices, and supporting self-care.
And the diagnosis part.
It's clinical, as I mentioned, relying on the patient's history, key things like the gradual onset of pain, exactly where it is, if it radiates down the forearm, and what makes it worse. Often actions like grasping or twisting. Then the physical exam looks for tenderness over that bony bit on the outside, the lateral epicondyle, and pain when they extend their wrist or fingers against resistance. There are also specific tests we use, like Cousins, Mills, or Maudsley's tests, which can help confirm things.
So no need for pricey scans straight off the bat.
Exactly. Plain X-rays aren't usually needed for diagnosis, and specialist imaging like MRI or CT scans are generally not required in primary care. Only really if there's genuine diagnostic uncertainty, or maybe a suspicion of something else going on.
And the initial treatment advice?
It focuses on patient education, explaining the self-limiting nature, advising on activity modification to reduce the irritating lows, giving them a break, and providing exercises, often focusing on stretching and progressive strengthening. Eccentric loading, where the muscle lengthens under tension, is commonly included. Plus, simple analgesics or NSAIDs are part of that initial plan too.
Okay, and what about those NSAIDs, the rubs and the pills? What's the evidence say?
Well, systematic reviews suggest NSAIDs, whether topical creams or oral tablets, can offer short-term pain relief, usually effective for up to about 4 weeks. But the evidence quality for both is actually low to very low. Topical NSAIDs are generally preferred because they carry less risk of systemic side effects, especially stomach issues, compared to the oral ones. The key point from the evidence, though, is that their benefit seems limited in time and is based on less robust studies.
Right. What about things like orthotics, those forearm bands or wrist braces you see people wearing? Do they actually help?
The BESCA guidelines give what's called a conditional recommendation here. They may be offered, but importantly, patients need to be aware that the evidence suggests they may not actually provide a benefit.
Ah, okay.
While some sort of low-quality evidence hints at an immediate effect on reducing pain during gripping, there's really no reliable evidence showing sustained benefit over time compared to a placebo or a sham device.
Okay, let's move to physiotherapy then. It feels like a very common and sort of natural intervention. What's the recommendation and the evidence look like there?
Physiotherapy gets a strong recommendation. Patients should be offered it. Evidence from systematic reviews shows strong evidence of benefit, but mainly in the short term.
Short-term meaning.
Usually the first few weeks, maybe up to 3 months. However, when you look longer term, medium and long term, there's generally no significant difference in outcomes compared to just, well, waiting for spontaneous recovery or receiving no specific intervention. Now, there is some lower quality evidence hinting at a possible long-term benefit from specific types of physiotherapy, but the certainty around that is currently low.
That's a really important nuance, isn't it? Helps early on, but maybe less clear difference compared to just getting better naturally in the longer run. What about for really chronic symptoms? Say someone's had pain for over a year or after surgery.
Yeah, for chronic symptoms beyond 12 months, dedicated high-quality studies are a bit thin on the ground. However, based on that short-term evidence at earlier stages, the consensus is that physiotherapy may still be offered, especially if it hasn't actually been tried properly before. And for post-operative physiotherapy, specific evidence is also lacking, but clinical consensus supports that it may be offered, to help guide rehabilitation and recovery.
Okay, now here's where I think it gets really interesting and maybe quite counterintuitive for many people. For ages, corticosteroid injections felt like the standard go-to treatment. What does the latest evidence actually tell us about using them?
This is probably one of the most critical takeaways, and it's backed by multiple meta-analyses and high-quality trials. The recommendation now is that corticosteroid injections should not be used for lateral elbow tendinopathy.
Should not be used. That's quite definitive.
It is. The evidence, which ranges from moderate to very low quality depending on the specific study, consistently shows only a minor temporary improvement in pain, usually just in the first month or so. But, and this is the striking part, by 6 months, the outcomes are often worse than if the patient had received a placebo injection or even no treatment at all.
Worse. How so?
The evidence suggests they might actually hinder the natural healing process and potentially increase the risk of the pain coming back recurrence. It's this long-term negative effect that underpins the strong recommendation against using them.
Wow, that reversal effect is huge. Clinicians and patients really need to know that. Okay, so if steroids are out, what about the range of other injections and therapies that seem quite popular now? Things like PRP, dry needling, shockwave therapy.
Yes, the evidence picture for many of these is, well, less clear or often negative when compared properly to placebo or sham treatments. For platelet-rich plasma, PRP, the BESS recommendation is conditional neutral, which basically means patients should understand there may be no benefit compared to placebo. The current evidence shows no significant effect on pain or function, and the quality of that evidence is rated as very low. Autologous blood injection, using the patient's own blood, gets a conditional recommendation that it should not be used. Moderate to very low quality evidence suggests no real benefit over simple saline injections.
What about dry needling? That seems quite common too.
Dry needling also has a conditional neutral recommendation. Again, patients should know there is no evidence of benefit compared to placebo. A key issue here is the lack of well-designed studies comparing it to a proper placebo or sham treatment. While some studies compare it to other things, steroids, ibuprofen, even surgery or PRP, The results are very mixed, making it impossible to draw firm conclusions about its effectiveness on its own merit.
And extracorporeal shockwave therapy, ECSWT.
That receives a strong recommendation. It should not be used. Moderate to very low quality evidence shows no clinically significant improvement in patient-reported outcomes, pain, or grip strength when compared to placebo or sham treatment in the medium term, say around 3 to 6 months.
Okay, so not much support there. And what about the really novel therapies? Things like ultrasonic procedures, dexterous injections, arterial embolization.
For many of those newer or more experimental therapies, the recommendation is also conditional neutral. Patients should be aware there's currently no evidence of benefit compared to placebo. The evidence base is typically very low quality, often just case series or small comparison studies. The consensus really is that these should only be considered within the context of research trials at this point.
That's a really clear rundown of the non-surgical side, thanks. Really highlights where the evidence stands or doesn't. Let's switch gears now and talk about surgery. Given everything we've just discussed, why is surgery even considered, and what does the evidence actually show about its role? Feels a bit controversial now.
It is quite controversial in the evidence-based world. Surgery is typically reserved for patients whose symptoms just haven't resolved after a decent trial of non-surgical treatment, usually defined as maybe 3 to 6 months in the BSS guidelines. The Muir Scoping Review, which looks specifically at the surgical literature, found the median time people had tried non-surgical options before having surgery in the studies was about 6 months. But you're right, its role is debated, as highlighted by both the BSS guidelines and that Muir review.
Okay, so what is the specific recommendation in the BSS guidelines about surgery? This feels like a key point.
It is perhaps the most surprising and important point regarding surgery. The recommendation states, patients being offered surgery should be made aware that there is no evidence of benefit compared to a placebo.
Hold on. No evidence of benefit compared to a placebo. That sounds... Well, how can that be? If surgery is being offered, surely there must be some evidence it helps. What did that Muir review actually find when it looked at all the surgical studies?
It's fascinating when you dig into why that recommendation exists. The Muir review analyzed 35 studies on surgical management, covering over 1,500 patients. What they found was that the literature is dominated by single-center studies, often with quite small numbers of patients in each. And there's a real lack of high-quality multi-center trials.
Okay, so the quality is maybe not ideal.
Precisely. And there's huge heterogeneity, meaning studies use different methods, different patient groups, measured outcomes differently. This makes it incredibly difficult to combine the data and draw really strong, generalizable conclusions. Now, most individual studies did report improvements in pain and function after surgery. That's true.
Okay.
But the critical issue is that these studies very rarely compared surgery directly to a proper placebo or sham procedure, or even to a well-structured conservative management program. The one trial they identified that did compare open surgery to sham surgery actually found no improvement in function in the group that had the real surgery.
Right. So many individual reports say patients got better after we operated, but the gold standard comparison surgery versus fake surgery didn't show a benefit for the real thing.
That's the crux of it. It really raises the question, are the improvements seen in many studies due to the surgery itself? Or is it the postoperative rehab, the placebo effect of just having a procedure, or simply the natural history of the condition resolving over time, which we know happens often anyway? Because of that lack of high-quality comparative trials, especially against placebo, the BSS committee couldn't find strong evidence to recommend surgery over doing nothing or having a sham procedure.
Does the evidence tell us anything about different surgical techniques, like open surgery versus keyhole arthroscopic surgery?
The Muir review didn't find consistent differences between open and arthroscopic techniques when looking across the literature narratively, although individual studies reported improvements with both methods. So the BSS guidelines basically say that if a patient does choose surgery, they may have either technique, but they note the evidence comparing them is limited by small study sizes and a lack of long-term follow-up measures. Percutaneous techniques were also looked at, but the data there is even more limited.
Okay. And finally on surgery, is recurrence a risk? Can the pain come back? And are there things that might make that more likely?
Yes, recurrence is definitely possible. A study mentioned in the BSS guidelines reported a 2-year recurrence rate of around 8.5%.
And risk factors.
Several potential risk factors have been identified. Things like older age, perhaps inadequate or short recovery periods after treatment or surgery, being involved in manual labor, having had previous surgery on the same elbow. Also, having symptoms for a very long time, say over 12 months, experiencing very acute pain right at the start, poor adherence to the recommended management plan, and notably, having received corticosteroid injections.
Ah, there are those steroid injections again linked to potentially worse outcomes or recurrence. That's really striking.
It reinforces the earlier point, yes.
Okay, wow. We have covered a huge amount of ground there, looking at the evidence for both non-surgical and surgical approaches. Let's try and crystallize some of this. Time for a quick lightning round for some sharp, concise answers. Ready?
Ready?
What's the single most reliable way to diagnose tennis elbow?
Clinical history and a thorough physical examination. Imaging is generally not needed up front.
Based purely on the evidence, if I start getting tennis elbow pain, what's the very first thing I should probably try myself?
Activity modification try to reduce the offending loads. Then, exercises, including stretching and progressive strengthening like eccentric loading, and maybe topical NFIDs for short-term pain relief.
Okay. What treatment, maybe commonly used in the past, does the evidence now strongly suggest people should avoid because it doesn't help long-term and might actually worsen things or increase recurrence risk?
Corticosteroid injections, definitely.
Got it. What's the biggest remaining question mark or area of uncertainty in managing tennis elbow, according to the recent literature we've discussed?
I'd say it's the exact role and the true benefit of surgery, especially when compared rigorously against non-surgical management or simply allowing for that natural, spontaneous recovery. We really need more high-quality, placebo-controlled trials.
Right, that comparison is key. And finally, if someone's tracking their own progress or looking at research, what's a key outcome measure that patients and clinicians should probably be aware of?
The PRTE, that's the Patient-Reported Tennis Elbow Evaluation Questionnaire. It's recommended as the core outcome measure for assessing disability in this condition.
PRT. Good to know. Excellent. Okay, to wrap everything up from this really insightful deep dive into your sources, let's quickly summarize, say, 5 key actionable takeaways for our listeners.
Absolutely. Let's do that.
Okay, first takeaway. Remember, diagnosis is primarily clinical. It's about the conversation with your doctor and the examination. Imaging usually isn't needed unless the diagnosis is really unclear.
Second, this condition very often improves on its own over time. Physiotherapy can be very helpful for short-term relief and function, but the evidence for its long-term benefit compared to just natural recovery is less certain.
Third, and this feels like a headline finding, the evidence strongly advises against using corticosteroid injections. Any short-term relief might be outweighed by worse outcomes later on and potentially a higher risk of the pain coming back.
Spot on. Fourth, for many other treatments that you might hear about, things like PRP, dry needling, shockwave therapy, the current evidence, when compared properly to placebo, is either weak, of very low quality, or simply shows no significant benefit. Be aware of that limited evidence.
And fifth, the role of surgery for tennis elbow remains quite debated. High-level evidence, especially from reviews including sham surgery trials, doesn't clearly show a benefit compared to placebo. So given this uncertainty, really understanding the evidence and engaging in shared decision-making with your clinician is crucial if surgery is ever on the table.
Agreed entirely. Making informed choices based on the best available evidence is absolutely key to managing this condition effectively.
So what's the final thought for you, the listener, from all this? I think it's that understanding the natural history of tennis elbow, the fact it often gets better by itself, alongside the frankly, surprisingly weak or even negative evidence for many common interventions really empowers you. It means you can have much more informed conversations about your treatment options. Knowing what the science actually says is the vital first step to choosing the path that's truly right for you. If you found this deep dive helpful, please do take a moment to rate and share the show with your network. Thank you so much for sharing your expertise and guiding us so clearly through these important sources today.
It's been my pleasure. Thank you for having me.
And thank you, our listener, for joining us on the deep dive. We hope this has shed some useful light on what can be an incredibly common and sometimes very frustrating condition. Until next time.